Welcome to Legal Eye on Health, your insight into health law, the ultimate podcast for unraveling the legal intricacies of managing a thriving medical practice. Join us for a deep dive into health law, specifically tailored for providers. Hosted by Dr. Katie Gilbert Spear, a seasoned health law attorney and practicing optometrist, as she brings her unique perspective and passion for empowering fellow practitioners. Together, we'll tackle the pressing issues confronting providers daily. Welcome to Legal Eye on Health.
Are you looking for a nutritional supplement to help with your day-to-day vision needs? Look no further than MacuHealth. Recommended by doctors worldwide, MacuHealth offers a full line of products designed to support your vision and eye health. Available through eye care professionals on Amazon.com and directly on our website at MacuHealth.com. Use the code LEGALEYE when ordering directly from MacuHealth for special discounts. MacuHealth, nutrition you can see.
Welcome back, everyone. Katie and I have had a great time walking through the whole world of standard of care. And honestly, we've actually been working our way through medical liability, which is, we talk negligence. There's so many words.
I know.
How about you just make it clear for us,
Okay,
Katie?
I'll tell you where we're at
Okay.
in the process. There is a process. So we've been talking about medical liability.
Okay, thanks.
And medical liability is basically just a negligence claim. And negligence has different elements to it. The first element of a negligence claim is a duty. So you have to establish a duty. And we did that with our previous episodes. We talked about the doctor-patient relationship.
Okay.
So when you have a doctor-patient relationship, you have a duty to your patient to adhere to a certain standard of care, correct?
Yes.
Yes.
Now I get it. And
Yes.
you have a duty, as you taught us, to properly terminate a relationship.
Correct.
We learned about that.
Yes.
So now let's talk about a breach of that duty. What is that?
Okay. So the second element of a negligence claim, just in general, is a breach of that duty. And in medical liability, it's a deviation from the acceptable standard of care. So that's what we're going to talk about today, is standard of care.
All right, so we're not going to hit that third thing? You said there's
Not
three?
yet. Well,
Okay.
there's actually 4. We'll get to those later. I know.
Okay.
It's coming.
A reason to listen to the next
Exactly.
one.
It's coming.
Okay, so now you just helped me to understand standard of care is where we live in this episode.
Correct.
So now tell us, what is standard of care?
Okay, I'm going to actually read you a definition.
Okay.
And there's like 1,001 definitions out there that just say, I think this one just is, the easiest. It's the level of care, skill, and treatment that is accepted and practiced by a reasonable and prudent healthcare provider under similar circumstances. So, if you're a physical therapist, an occupational therapist, an optometrist, a dentist, whatever, you're a medical provider, and you have certain standards of care within that profession that if you deviate from,
Right.
could be, and they cause damages to a patient, could be cause liability. You could have liability from it.
So I assume that the standard of care has changed over time, because you told us that, sort of.
Yeah,
but
definitely.
Let's go back in time. What is the oldest time that you've researched where standard of care was looked at, and what was it considered then?
So I love history, April. History is my jam. So I'm going to go way, way back to the 1900s. Okay. So basically, prior to the 1900s, early 1900s, the standard of care was whatever was customary. Customary is just customs, right? It's whatever people within
Most
that
people do.
Yeah, if you do it, then I do it, right? If the majority of practitioners do it, then that's what the standard is. There's 2 cases that changed this in the 1900s. The early 1900s was a case called T.J. Hooper, and it's about tugboats and barges, which is weird.
As in boats?
Like in the water. Yeah. It has nothing to do with medicine
Okay.
in general, but very relevant, I promise. So stay with me. So what happened was there were tugboat and barges in this in a storm. And I won't go into all the details, but the tugboats did not have radio receivers to actually be warned about this storm, and then they had a lot of damage, the barges did. And so they were sued, and they argued that that it was customary for tugboats to have radio receivers, and if they'd had those receivers, then they would have been warned of the storm and thus would not have had damages.
Wow.
So this actually made it all the way to the Supreme Court, surprisingly. And the Supreme Court ruled that it wasn't just a customary standard, meaning that most tugboats have radio receivers, that it was a reasonable standard, because why would you be in the middle of some water somewhere and not actually have a radio? Like, that just doesn't make sense. If you So, and they said, this is from the case, even if a practice was not customary, it didn't have to be customary. If it was just reasonable, then it could still be used as a standard of care. So that's what the decision was. And so we fast forward to the 70s now.
Okay.
And this actually is a medical liability case. It's a medical malpractice case. And so, and I like it, April, because it has eye care in it.
Oh,
I
good.
know. See?
It'll relate to me.
It will. You'll understand it. And so what happened was a patient who was nearsighted or myopic. She was a contact lens patient of an ophthalmologist for many years. And she saw him many times over the course of several years. She complained about irritation and certain things off and on.
When did this all start? So
it started in
1959.
1959. It's when she first became a patient.
Okay. And the tugboats were early 1900s?
Early 1900s, yeah. And so
it.
like in 1963, she came in complaining of irritation from the contact. She came in again 4 or 6 times, different years. In 1968, so 9 years after she really became a patient of the ophthalmologist, he checked her intraocular pressure, her IOP, and her visual field. And she was diagnosed with glaucoma at 32 years old. Isn't that crazy?
Oh, wow.
And because that is really rare.
Unusual, even today.
Yeah, even today. And when she was finally diagnosed, she had vision loss, peripheral and central vision loss. And she sued her ophthalmologist for failure to diagnose glaucoma. And the ophthalmologist's argument was, of course, it's not customary to check intraocular pressure on patients under 40 because the prevalence of glaucoma for patients under 40 is very minimal. And the court did their investigation and all the stuff, and the court ruled that because we know that checking IOPs on a patient is not invasive, it's pretty easy to do, and because it was inexpensive and harmless, that it should be offered to the patient. And the court actually quoted the decision from Hooper.
The tugboat.
Yes, the tugboat. And said, don't care if it's not customary. Got it.
Oh my gosh.
But it's reasonable because the test is cheap and it's not invasive. You're not having to cut into somebody. So if you had checked her pressures and found it early, which you could have done very easily,
right,
then she would not have lost the vision that she lost, because we know that glaucoma is progressive. So that was the decision. And then after that, a lot of different states started passing legislation around standard of care, because prior to that, there really wasn't much in the legislative arena.
Right.
Yeah.
So let's say, though, that a case like this, I mean, even that case, I'm sure they had, and what's typical in any case that is brought to a malpractice group, they have expert witnesses, right?
Correct. Yes.
So the expert witness would say that it was customary or reasonable.
So and now in today's arena, you have to, in most cases, most states, you actually have to have an expert witness. A lot of states, you have to do like a pre-suit where you have to show that you have an expert witness that would testify that there was a deviation from the standard of care. The standard of care is very, it's hard to pin down because, as you know, patients are so different. So what you would do with one patient versus another patient, it's so nuanced. And so you have to have an expert to view that patient's record and really make a determination of, was there a breach of standard of care?
Right.
And so,
and what will they use? I mean, is there ever a time when an expert they're not going to just go by what's in their head, even though they're an expert, they're going to use something to look at?
I mean, they usually will use published guidelines. So there are clinical practice guidelines, CPGs is what, and the American Academy of Ophthalmology has them.
Yep.
The AOA has them. There's, every national, I think,
And they update them regularly.
They usually do. Most of them are updated every time certain, a new treatment comes out, a new technology comes out. And so that's the whole reason that we have, continuing education, is so that we stay up to date on these new treatments.
Maybe in the old days, people didn't find out very quickly about updates, but today, I don't know that we have
you
much
don't
excuse.
really have that argument now. You carry a computer in your pocket. So before, I think that because of technology, you may not have the newest, latest, or greatest, CT scan or whatever it may be if you're in a rural hospital or something like that. But today, and you may not have the Lancet or the new journal or whatever in time to find something. I don't know. But here, in today's society, we have information at our fingertips. So that really doesn't pass muster today.
And it's not even just technology. Like in that case, they should have done extra testing. That wasn't customary at the time, and today it is. But sometimes it's not even technology. It's a treatment option or plan that's changed. So give us some examples of when standard of care changes. What pushes that along?
Okay. Well, I know some examples in eye care.
Yeah,
just because actually they just happened recently. Well, I would say fairly recently. But I think a really good one is the corneal cross-linking for corneal ectasia or keratoconus. The American Academy of Ophthalmology actually has preferred practice pattern guidelines that I use in my practices because they update them very often when new treatments come out. And they changed their one for corneal ectasia in 2016 to include corneal cross-linking, and basically saying when you see, and they updated them again actually in 2024. When you see corneal ectasia or keratoconus progressing, then instead of, what did we used to do before corneal cross-linking?
Just to refit them in new contacts, do whatever we needed to do to make their vision better, but really there wasn't anything other than to say, I'm sorry, it looks like it's progressing and you might need a corneal transplant one day.
At some point, right? And so I think especially when you have a treatment that changes it to the point where before there was no preventing it progression, and now you have a treatment that prevents progression, that's where that standard of care really does change. And that's the case in corneal cross-linking, because now, once you first see any type of progression, if you get them cross-linked, then they usually don't progress. And so that's a huge game changer. Another one in eye care is myopia control. There's a lot of nearsighted people out there, right?
And more every day. So, and we know myopia is, as it progresses, can lead to diseases such as glaucoma, retinal detachment. So that would be a big one to stay up to date with. So tell us about that.
And we know that there's been a lot of research done on this in the past decade, and there are there's several, national and international organizations that have called this. In fact, the World Council of Optometry passed a resolution in 2021, 3 years ago, stating that the standard of care that for myopia management, meaning that instead of just fitting a child in glasses or contacts to help them see better, we should be controlling the myopia with treatments that we know will slow the progression. And so I think that the standard of care in those two areas are definitely changing.
What about screening patients for different conditions? Is there any resource that helps you to know what's the latest? So give us some ideas of resources there, and then what are some examples of areas that have changed outside of optometry?
So I think that, I love this website. It's called uptodate.com. They actually have everything from primary care to, all the subspecialties in medicine. And they seem pretty consistent with updating the different areas with new research comes out, or a new guideline. For instance, the European Hematology Association came out with a new screening guideline for iron deficiency before anemia develops, and they say that they suggest screening like athletes, vegetarians, blood donors, and certain things, and so certain groups before anemia is actually developed because they are at a higher risk. And so I think you take that change where it's an international group somewhere, and say, okay, well, maybe we should change that here. And they actually have published guidelines on their website too. But I think whatever specialty that you're in, that's why we have continuing education. You need to make sure that you're keeping up to date. Here's, I teach a class at UAB for optometry students, and one of the things that I love to say to them is ignorance is not a defense. So just because you didn't know does not mean that you shouldn't have known.
Right.
Because
keep going.
No. That is that's the reason why every state has guidelines around, in whatever profession you're in, continuing your education, because who wants to go to a medical provider who's still practicing the way they practiced 20 years ago?
Right.
No.
And I want to be able to go and sit and listen to a class.
Right.
And hear something new.
Right.
And know that I'm protected and I'm educated as to what I didn't know because I've been out of school for 15 years.
Right.
Longer than that. But we'll say
a little bit longer, right? And so I think that's the key here, is that to make sure that you're going to education where you're, and maybe education that's not necessarily in your specialty, right? So good. Like, I know the American Diabetes Association, they published a whole standards of care in diabetes in 2024, which updated the screening, what you should think about for patients that have comorbidities with this and that. And so I think looking at that and saying, I mean, diabetes is big in eye care, right? So maybe I should look at that, because I shouldn't, even though I'm an optometrist, I'm not just concerned about the patient's eyes.
Right.
I mean, a lot of my patients have diabetes. Right. So I need to make sure they're getting their screening for other things. Sure. And it's not, or if you're a primary care physician and you've got a lot of diabetic patients, making sure that they get their eyes checked, because we know that that's one of the leading causes of blindness. And how we all work together. Right. I mean, imagine you're a patient listening to this right now, because we're all patients as well. Right. Mm-hmm. I love Up to Date, because I go to that website. So my sister, as you guys know, is a doctor as well, and other family members that I have, we all use this as a resource. Right. And I love going and looking up my own stuff. Right. Mm-hmm. Because I can look up any medical condition and I can see what is the latest research on diagnosis, treatment, technology that should be used. And as soon as the guidelines change, as a patient, I can go to my doctor and say, hey, I saw this. What do you think? What do you think about it? Yeah. Which is like, if it's happened to you before, which it has unfortunately happened to me, you're like, oh, wait, what? I need to go look that up. So it's good. I mean, it keeps us all, as my mom used to say, it keeps us on our toes. Yes. And it keeps us out of harm and legal liability. Yes. I don't want to go there. So I love it. Well, I think that's a good place to end this segment. Katie, what would you say as a summary of what we've talked about in this episode that people need to be thinking about and kind of their take-home action items? I think just making sure that you keep up to date with current treatments, current technology. If you don't have, like I know within our profession, some people may not have certain machines that can detect things earlier rather than later. If you don't, then partner up with somebody that does. Just because you don't have a machine or you don't offer that treatment or that technology or whatever it may be, doesn't mean that you can't be held to that. Right, so, that's good. So just make sure that you have somebody that you can refer to. Yeah, if you don't have it. And you gave us a great tip earlier. Make sure that you have a protocol in your practice so that you follow it every time, every single doctor. Mm-hmm. And you even have written materials that you've made on these different different areas, right? We do. We have guidelines within our practice, because I tell my associate doctors, I'm not gonna doctor for you. You can do, because every patient is different. However, having guidelines for them to use to say, okay, when I have this type of patient, this is the workup. This is when I typically bring them back. It helps with navigating that patient through whatever it is they have, but also with billing and coding, which we'll talk about down the road. Because there's certain areas in billing and coding where you need to bring the patient back at this time, rather than this time. So there's a lot of, having just guidelines within your practice, I think helps in every area. Good. I'm the protocol queen. I love it. And I think it's great that we're sharing it with people. Yes. That's what we all need, is just helping each other so we can all do a better job for our patients. Right. We try to keep it to a close to 15-minute segments for you guys, so we're right there, and we just want you to know how much we appreciate you watching and listening. And Katie's amazing. I'm just so glad we have her as a resource. But if y'all got questions, I would love to hear questions. Oh, that's a good point. That would be awesome. Send them in to us. We will make sure that we talk about them, or she will. Yeah. I'll just ask her questions. Thank you, April.